Hi students, I'm Dr. Siddharth Sethi and today I'm here on Facebook to discuss with you a new hormone and a new therapy. It's very important for your exam and I'm Dr. Siddharth Sethi. You can always find me on Facebook and on DAMS Club. So first of all, when we talk about the phosphorus metabolism today, you need to know that most of our phosphorus is absorbed with the help of vitamin D by acting on the intestine. Okay. Now, number two, now phosphorus in our body is reabsorbed or resorbed basically with the help of PTH by acting on the bone and the kidneys. Now, today we will be concentrating on a new hormone which is very important for the exams called FGF23 subtype. Now, what is FGF23? It acts on two places. Number one, it acts on the proximal tubular channel called sodium phosphate co-transporter. By acting at this sodium phosphorus co-transporter channel, this FGF23 reduces the absorption of phosphorus. Okay, so less phosphorus goes to the blood. So remember, especially it acts at this channel, sodium phosphorus co-transporter 2A and 2C, and it reduces the absorption of phosphorus into the blood by acting at the kidney proximal tubule. Now, what FGF23 exactly does is it is a phosphotonin. That is, it reduces the serum phosphorus by acting at the kidney. I told you the proximal tubular cells. Remember, FGF23 is secreted by osteocytes with the help of clotho. It is a co-receptor for FGF23 and FGF receptor. So basically, just remember these are two receptors. It leads to reduced phosphorus absorption in the kidney. Number two, FGF23 reduces the 1 alpha hydroxylase of the vitamin D. So, in a way, it reduces the active vitamin D and reduces the absorption of phosphorus into the intestine. So, again, it leads to reduce serum phosphorus. Now, what is the most important stimulus of FGF23? Increased serum phosphorus. So, for example, in patients who have chronic kidney disease, now all of us know that in fact, whenever the mineral bone disease occurs in chronic kidney disease, the first marker which rises is FGF23 even before PTH. Okay, so in kidney disease, chronic kidney disease, FGF23 rises first. Now, it may also rise if you have a disease, for example, X linked hypophosphatemic rickets, because of a mutation in the FEX gene. Remember, FEX gene. It can also happen in some tumors which secrete FGF23. Okay, so there are some tumors, for example, fibrous dysplasia, epidermal nevus syndrome. I remember when I was in All India Institute almost 10 years back, this is 10 years back, 2010, at All India Institute, we found a child who had these nevi on his body and had very severe hypophosphatemia. We published that in a journal. And removal of these nevi improved his rickets. Now, today I am talking to you about a very important kind of rickets called X linked dominant hypophosphatemic rickets. It's called X linked dominant hypophosphatemic rickets, which is more severe in boys. Remember, this is the most common phosphorus wasting disorder because of mutation in the FEX gene. And in this disorder, also, there is high plasma FGF23. Now, I'm not in All India Institute right now. I'm a pediatric nephrologist at a hospital in Gurgaon. So I have collaborated with multiple doctors in US, in Michigan, and we've been working on FEX mutations in children whom we see with hypophosphatemic rickets. Now, why am I talking about this? Is that the pathogenesis of hypophosphatemic rickets is increased FGF23 from the osteocytes, which leads to low serum phosphorus and also reduced 1 alpha hydroxylation. So, till now, friends, the treatment of X linked hypophosphatemic rickets was to supplement these children with phosphorus and to give them active vitamin D. Now, students, remember that you will be given a case scenario in your exam, a child who has low serum phosphorus, increased alkaline phosphatase, rickets, more in the lower limbs, a normal PTH. Remember, normal PTH is striking because this is not vitamin D deficiency. This is phosphate urea, phosphate loss causing rickets. Now, why am I talking about this today? Because in the last 2 years, what has happened is there was a very big study published in the New England Journal where they found that you can use a new monoclonal antibody called borosumab. Borosumab inhibits FGF23. It is a new monoclonal antibody, and it has been found that this borosumab maintains the serum phosphorus levels in these children. And now this is the drug of choice. It's a subcutaneous injection and it's FDA approved. And even in our country, there are some children who have been already started on borosumab. So remember about this new hormone and this new therapy, and I bet it's gonna come in your exam. I'm Dr. Siddharth Sethi, a pediatric nephrologist, and your pediatric faculty, signing off, and stay tuned for more videos in future. Thank you.